Intermediate uveitis. One question and still residents lose their marks in exam. Welcome to my channel, Ophthal Exams and Viva. And today we are going to discuss intermediate uveitis. Every PG, every resident, MS, DNB, ophthalmology, they have the knowledge of the topic, but they still lose their marks in exams because they don't know how to structure it in exams clearly. Today I am going to give you one framework and everything what you need to mention in your exams, important Viva questions in just one video. So stay with me and let's start. Okay, so let's start with intermediate uveitis. So please listen to each and every word carefully because I'm going to teach you a very important topic covering all the points to be written under long answer question and the questions which are asked in Viva. So first we start with the definition. Any answer start with a clear definition. In definition, you mention that it is chronic, relapsing, intraocular inflammatory disorder that involves pars plana of ciliary body, peripheral retina, and anterior vitreous. So, intermediate uveitis, the primary site of inflammation is mainly anterior vitreous. So, this is important to remember. And standardization of uveitis nomenclature. It divided intermediate uveitis into pars planitis, pars cyclitis, or highlightis. So if you see pars planitis, pars cyclitis, and highlightis, this is based on Sun working group classification. But if asked in Viva, what is the primary site of inflammation? It is important to mention that it is mainly the vitreous inflammation, the main site of inflammation. So you remember this definition for intermediate uveitis. Now for epidemiology, it is important to know certain percentages. I have taken this from Yanov. So if you mention these percentage only, it is more than enough for epidemiology. Now see one by one. If we say 1 to 26%, it is intermediate uveitis accounts for 1 to 26% of all uveitic cases. Annual incidence of intermediate uveitis is 1.5 to 2.1 lakh. 10 to 12%, intermediate uveitis accounts for 10 to 12% of pediatric cases. You have to remember that 80% of intermediate uveitis are bilateral, especially in West, and in India it is 40%. But in general, as you'll say that it is usually bilateral in 80% of cases. So you remember that intermediate uveitis is generally bilateral. So this is just to mention in exams so that epidemiology section is covered. But for Viva, what is important is that you know what is bimodal, that intermediate uveitis has bimodal distribution. And it affects 5 to 15 years of age patients also, and then 20 to 40 years of age. So when this age is covered, mainly it is male dominant. When 20 to 45 years of age is covered, it is mainly female predominance. But Yanov says, this I have taken from recent articles, but Yanov mentioned that bimodal distribution less than 7 years and 20 to 30 years. So you can quote any of these. If you want to quote Yanov, you mention this bimodal distribution, and if you want to quote recent articles, this is also correct. We come to very important part, which is etiology. It is very confusing. Here I am going to give you simple flowchart and very important causes for intermediate uveitis, which is important for writing in exams, for Viva, and based on clinical aspect also. So first of all, etiology, we divide into idiopathic intermediate uveitis. Causes could be infectious, inflammatory, or we call it non-infectious, autoimmune, TINU, and masquerades for any malignancy. So we'll discuss one by one. So let's talk about idiopathic intermediate uveitis. So in 2021, Sun Working Group classification divided idiopathic intermediate uveitis into pars planitis and intermediate uveitis non-pars planitis type. How did they differentiate both? That pars planitis is also one of the idiopathic entity. It is pars planitis with snowballs formation and snowbanking formation. We will discuss it in clinical features. What are these? Just remember that pars planitis along with snowballs and snowbanking, in absence of any systemic disease, when you rule out other causes of uveitis, it is pars planitis. Whereas in intermediate uveitis non-pars planitis type, there is only vitritis and no identifiable cause. But actually the snowballs and snowbanking are absent here. So can you differentiate it now? That idiopathic intermediate uveitis is when no identifiable cause is there. But if you have to call it pars planitis, it is important to have snowballs and snowbanking. And if you call it non-pars planitis type, then only vitritis is there. So this is important. Now, different percentages are there that AAO, American Academy of Ophthalmology, it mentions recently that it is 80 to 90% of time intermediate uveitis is idiopathic. Cancer, it is mentioned 50%. So you can quote accordingly. So it is very important for this. Etiology overall is very important for Viva because examiners generally confuse you in idiopathic, non-idiopathic, infectious cause. They will just keep on confusing you with so many etiologies. So you should be very clear in your mind. So I think idiopathic intermediate uveitis is now clear. Now, next important cause is infectious cause. So infectious cause में three most important diagnoses you have to remember. TB, because India being the most epidemic for tuberculosis, TB is one of the first diagnosis which has to be ruled out. So tuberculosis, then syphilis. Syphilis is known as the great masquerader. So it is very important that you rule out syphilis in all the cases of intermediate uveitis. Another is Lyme. It's a tick-borne disease and it should be ruled out. So you remember in infectious causes, TB, syphilis and Lyme. Mainly examiners are fond of asking and they want to listen to these infectious causes. Others are also there: toxoplasmosis, toxocariasis, cat-clutch disease. For exams, you can write, there's a big list, but it is important that you know the basics. Now, next important part is inflammatory cause. Sometimes uh, examiners in Viva, they ask, give me the non-infectious cause of intermediate uveitis or inflammatory cause. So you remember one important disease, which is sarcoidosis. It is very important. Sarcoidosis, the most common manifestation is generally anterior uveitis, but 58% of cases, they can have intermediate uveitis. So it is important that you rule out sarcoidosis also. Then remember autoimmune, multiple sclerosis. I'll give you Yanov percentages from Yanov. With 7 to 16%. You remember that this is prevalence of MS in intermediate uveitis cases and 1% prevalence of intermediate uveitis in MS cases. So this is very important and very confusing percentage. So you remember that the prevalence of MS in intermediate uveitis cases is more, whereas there is only 1% of prevalence of intermediate uveitis cases in case of MS. So these are two important percentages. Now, if we ask what is the most common ocular manifestation of MS, what will you say? Yes, that is optic neuritis. Remember, if the most common ocular manifestation of MS is asked, then you remember that it is optic neuritis. But patient with MS uveitis, if it is asked which is the most common presentation, then you say that it is intermediate uveitis. Clear? So these are little confusing, but if you listen to me again, it will be clear in your mind. So listen again, 7 to 16% prevalence of MS in intermediate uveitis cases. This is MS का prevalence in intermediate uveitis cases and 1% this is intermediate uveitis cases का prevalence in MS diagnosed cases. ठीक है? If it is asked that uveitis और MS का association किस में देखा जाता है, then you say intermediate uveitis. Are you clear now? So this is very important part and very important in Viva. TINU, not every PG student is aware of this and TINU is recently very commonly asked. So what is TINU? Give me the full form. So TINU is, you remember, U से तो आपको पता है it is uveitis. So TINU is tubulo interstitial nephritis and uveitis syndrome. So TINU is a syndrome with involving kidney and eyes. So you remember that it is bilateral intermediate uveitis with association with kidney. So it is generally seen in 0.1 to 2% cases, mainly females में होता है, and it is a bilateral disease. Masquerades or any malignancy can present as intermediate uveitis. So sometimes it is very important to keep this diagnosis as one of the differentials, especially when the person is more than 50 years of age and it is bilateral intermediate uveitis, especially in more than 50 years of age. So most commonly seen is PVRL. What is PVRL? PVRL is primary vitreoretinal lymphoma or any intraocular malignancy. So this part you not miss it in intermediate uveitis even while writing exams or even while giving your Viva. So you remember this much for etiology. I think it is more than, I think, no, I believe, I must say that this is more than enough. I'm going to give you a mnemonic to remember all this. Just, I'm going to give you a trick. So it is intermediate uveitis. So you remember I. So you remember etiology के लिए सब कुछ I. It is idiopathic. It is infectious. It is inflammatory. Then remember immune. Then remember I say inu, tinu, inu, and malignant. So you remember intermediate uveitis. I, 1, 2, 3, 4, 5. So 5 I's and malignancy. Now, next part is clinical features. So it is important that you divide it into symptoms, signs, and complications. So we'll divide into 3 parts. Now listen carefully that you can write symptoms of uveitis as pain, photophobia, redness in any question of uveitis. But what is important for specifically for intermediate uveitis that it has floaters as main history in 60% of cases and diminution of vision. So these two symptoms, it is important that you mention these two symptoms. Now, because the main primary site of inflammation is vitreous, so there are floaters. You mentioned floaters and diminution of vision more than pain, photophobia, and redness. This percentage I've taken from Yanok. You can mention it. Now, next important thing is grading. Science. First, you have to learn about grading of vitreous haze and vitreous cells based on a thin blood scale, and then we go on discussing other signs. So, you know, the first sign you see is vitritis in intermediate uveitis. So, it is always important to mention grading, and this is examiner's favorite question in intermediate uveitis to ask. They want to know grading between of vitreous haze and vitreous haze. So you remember that as 0, 1 plus 2 plus 3 plus 4 plus, and vitreous cells it is 0. सिर्फ एक 0.5 plus add हो जाता है, otherwise it is same 1 plus 2 plus 3 plus 4 plus. Now how will you remember? You remember that RNF vessels and optic disc. So when everything is clear, it is 0. When RNFL is little hazy, it is 1. When everything is little hazy, it is 2 plus. When only vessels are hazy, it is 3 plus. And when optic disc is also not seen, it is 4 plus. Easy? You remember like this. In vitreous cell, there is only one extra grading, which is 0.5 plus. Otherwise, it is 0, 1 plus, 2 plus, 3 plus, 4 plus. So you remember that for 1, it is 1, 1. So 11 to 20. Now for 2, it is 2, 2. 20 to 30. For 3, it starts from 3, 30 to 100. And 4, it is more than 100. And for 0.5 plus, it should be less than 11. So it is 1 to 10. There are 0 steps. So this, I think, just one trick to remember vitreous haze grading and vitreous cells grading. So you can remember it like this. Next important sign, that intermediate uveitis, we always talk about it. It is all about snowballs and snowbanking. Now, it is very, very, very important part of this topic because examiners will definitely ask you the difference between snowballs and snowbank. So you have to remember this word to tell him, because sometimes, okay, and they want to listen to these words only. So snowballs, you remember, whitish focal collections of inflammatory cells and exudate in the inferior vitreous. So this is important. Whereas snowbanking, these are gray-white fibrovascular plus along with exudative plaque, or you can say it is a now conglomeration of inflammatory exudate but at inferior pars plana, and they start inferiorly and they extend throughout 360 degrees. So this part is very important that you revise it again and again so that you do not get confused. Snowballs are in inferior vitreous, snowbanking is on the pars plana, right? Now, if you see that inferior pars plana has been involved with inflammation, so obviously nearby it there will be peripheral periphlebitis because venules will be involved due to inflammation, and this is especially seen in multiple sclerosis cases. Then if this much of inflammation is there, definitely it will complicate to peripheral neovascularization, and when neovascularization is there, new vessels, it will definitely bleed, causing vitreous hemorrhage. Then traction or fibrous detachments will be there. There could be cyclitic membrane over ciliary body, which can cause finally hypotony. So these are further complications, and because of these chronic inflammation, you have cystoid macular edema. And this is very important because this is one of the reasons for decrease of vision in intermediate uveitis. So this is Viva question. Please mark it, guys. Another or other complications are cataract, retinal membrane, band-shaped keratopathy, generally pediatric cases में देखा जाता है, and glaucoma. Right? Now, all this inflammation, sometimes it spill over to the anterior part, and that is called anterior uveitis or spillover anterior uveitis. In 57% cases, it is seen, and the reaction is very mild. So whenever you have case of anterior uveitis, it is always, always, always important to dilate the patient and look for intermediate uveitis or other cause of uveitis. So even if the patient has anterior, you have to dilate the patient to look for intermediate uveitis, right? So this I have given you a very simple way to learn and what are the important signs that you are expected to mention in exams, lighting them, and you can always write inside each of the headings. Now we come on the investigation part. Now, investigation, to remember it very nicely, I have divided it on the basis of etiology. If you remember etiology, you can write investigation without just remembering it. Let's see how. So you first divide into investigation for uveitis, then whatever the etiology we have discussed, then ocular imaging, especially specifically for eyes, which is mainly nowadays called multimodal imaging. Then if nothing is positive, then we label it as idiopathic intermediate uveitis, and little bit about diagnostic vitrectomy will be discussing. You know uveitis. For uveitis, you will look for acute phase reactants in the body. So you'll go for CBC, ESR, CRP, RFFR. Now we go for etiology wise. So for infectious cause, first of all, we decided to rule out TB. So for TB, what are the tests? You know, TB के लिए you do MON2 test, quantiferon TB test, HRCT test. HRCT2 mainly look for lymph node pathy, mediastinal lymph node pathy. For syphilis, so we have finished TB, then syphilis. For syphilis, you will do VDRL test or fluorescein test for antibody testing. Then for Lyme, you go for serology testing. So in this way, you can mention all these tests. Now, for inflammation like sarcoidosis, it is important that you get serum angiotensin converting enzyme, serum lysozyme, serum calcium, and that's HRCT chest. Why HRCT chest? Mainly to look for bilateral hilar lymph node pathy. So sometimes examiners ask this, that what it is there on chest X-ray or CT chest that you are looking for TB and sarcoidosis. You can mention BHM. Then for MS, you will go for MRI brain. TINU, we have already discussed kidney and eye. So one of the most important tests is urinary beta-2 microglobulin. It is a screening biomarker for TINU. If the specialist has done specialization in uveitis, he will definitely going to ask you about TINU in intermediate uveitis. So it is important for thyroid. Then for malignancy, if you suspecting malignancy or meth, you go for diagnostic vitrectomy. Now for diagnosis, so these are the, and you can get samples by vitreous aspiration, vitreous biopsy, or chorioretinal biopsy. We will be discussing after some time. Now for multimodal imaging, you go for digital color fundus imaging, color photo लेंगे, wide field imaging, इसका wide field चाहिए होगा because you want to see the peripheral retina and pars plana, ciliary body also. Then most important you need to mention is OCT and FFA because they are the main because these are the main investigations which will mainly tell about the cystoid macular edema, retinal membrane, neovascularization, any complications. So it is important. Now, B-scan can also be used to confirm exudates in the vitreous or any detachments or any complications can be seen. Similarly, UBM, pars plana exudates are seen on UBM. So you can write about this multimodal imaging, and it is important that these tests are mentioned while giving the written exams. Now, for idiopathic intermediate uveitis, I'm sharing this photo with you. Now, this With this table, based on sun working group classification, it is very clear that when do you label idiopathic intermediate uveitis. Just remember this and it is enough. So we have completed with the investigation list for intermediate uveitis. Very tailored approach I have explained you. Just remember this part at least so that you can score very well in your exams. Now, small part regarding diagnostic vitrectomy, because sometimes retina specialists, if they are your examiners, they are very fond of asking about diagnostic vitrectomy. So it is important that you know what is the indication for diagnostic vitrectomy, what are the techniques, and what are the tests you do via diagnostic vitrectomy. So what are the indications? Mainly to rule out malignancy. In cases of atypical presentation, non-responsive to conventional treatment, and rapidly progressive disease with inconclusive, non-invasive workup. So you remember these indications and it is sometimes asked. Now, as we asked about the technique, so we can take vitreous aspiration. So 23 gauge needle in a 2 ml syringe. You take 0.2 to 0.5 ml of vitreous. Side effect is that vitreous traction can be there and which can lead to retinal detachment. So just be careful. Then second, vitreous biopsy. It's also a diagnostic vitrectomy. It is done under peribulbar block. Standard two-port vitrectomy or single-port technique can be followed. So 1 ml of vitreous by vitrectomy cutter with cutting rate of 1200 to 15 meters per minute can be used. Therapeutic vitrectomy can also be done like PPV, which we will discuss in the treatment part. Okay. Now, what are the tests you send? So you take the sample and set for cytology, viral culture, PCR, antibodies test, and flow cytometry. Now, if we talk about malignancy, as we know PVRL, so it is important that you send the sample for interleukin 10 and interleukin 6 ratio, which should be more than 1 in PVRL, and there is a mutation in MYB88L 265P gene mutation is also seen. If these two things are confirmed, this is by PCR, gene expert. This is by mainly gene expert, PCR, and interleukin test. It is confirmation for PVRL. So you remember just this page for investigation. Every part of it is explained, and बाकी तो आप बीच में जितना चाहे पढ़ सकते हैं, लिख सकते हैं, right? And now comes the very important part of intermediate uveitis, the most confusing part, what to tell first, what are the things inside it. And wow, beautifully I have given you this flow chart and point-wise answer. Please remember this page and you will never be in confusion. So let's start. So there is a modified Kaplan's algorithm which gives step-ladder approach for intermediate uveitis management, and the mainstay of treatment remains the corticosteroids. Now there are different ways you can give corticosteroids in cases of intermediate uveitis. First, periocular means mainly posterior subtenon injection के फॉर्म में देते हैं. 0.5 to 1 ml of triamcinolone acetonide, which is 40 milligram per ml injection, and it can be repeated every 6 to 8 weeks. Then intravitreal form, if you are giving into the vitreous. So intravitreal triamcinolone acetonide, same, it was given as TST, can be given as intravitreal also. Now there are certain implants, like slow release implant or sustained release implant. Now this is very commonly given to the patient, which is 0.7 milligram dexamethasone implant, commonly known as Orzural, and 0.19 milligram of fluocinolone acetonide, commonly famous by the name Luvine, or 0.59 milligram of Retisol. So remember that these are the ways you can give steroids intravitreally to the patient. Now, systemic, everybody is aware that oral systemic can be given prednisolone 1 milligram per kg per body weight over 4 to 6 weeks with tapering doses. So this is important. So exam for writing in exams also, and what will examiner ask? That tell me the multiple ways that you give intravitreal. So you should remember IVTA, you should remember slow release implant and sustained release implant regarding this. Now, next comes steroid sparing and immunomodulatory therapy or biologics. So when steroids are having side effects, or they are patient is not responding, or there is recurrence, or still the bilateral vision threatening situation is there, you stop these steroids and shift the patient to steroid-sparing drugs. So drugs are methotrexate and cyclosporine. This you are aware. Just mention the names and whatever the mechanism of action you are aware of. Then second important is biologics like anti-TNF alpha, like adalimumab and infliximab. Nowadays, adalimumab is very commonly used biologic in intermediate uveitis. So it is important that you remember this name and mention in your exams and Viva. Always remember that these drugs are mainly given for non-infectious intermediate uveitis. It is very important that first you rule out infectious cause, especially tuberculosis, and then only go for biologic. Next is laser that I mentioned, cryotherapy or laser photocoagulation. This is just adjunctive treatment. You can go for inflammation and if there is neovascularization. Another is pars plana vitrectomy. Obviously, when this medical treatment is not working, right, then you go for vitrectomy or in complicated cases. Then next, you treat the complications, cataract surgery, glaucoma, ERM, CME, you mentioned, you treat accordingly. Next important thing which generally PGs forget to mention in exams while writing their answers, that it is okay that you give steroids, biologics and this, but if you do not treat the underlying cause, the intermediate uveitis is not going to be treated. So it is important that if you are having TB, it is important that you give ATTs first and then start the steroids. It is important that you do not give steroids without ATT. So this you need to mention, and this is very important part to remember. In sarcoidosis also, you give steroids, but the duration is little longer. You give for more than 3 months based on the patient response. You continue steroids for long. Similarly, like penicillin for syphilis, you go for benzathine penicillin. For malignancy, you go for oncology. For PVR malignancy, you go for oncology review and chemotherapy or radiation therapy. And similarly for MS. Treat intermediate uveitis in just this way, and there is no other way of treating it. So just remember this page. Beyond this, you don't have to know any other part. Just keep on reading so that you can elaborate on all under these headings. If you want to gain more marks, then mention about the clinical trials I just spoke about. There are certain clinical trials, COT, point trials, site study, fast Vitritis trial, and this I will be discussing in my next video. Till then, just remember what I have taught you and revise it. Now, let's see the framework which I showed you initially, that you are able to write and understand it now completely or not. Wow, beautiful. So if you know this framework and you know what to write inside it, you don't have to read intermediate from anywhere else. So let's start. First, we will mention about definition that we discussed, like chronic, relapsing, intraocular, primary site of inflammation as intermediate uveitis. You mentioned about sun classification also, which divided into parts, which divided it into pars planitis, pars cyclitis, and highlighted. But important to mention anterior vitreous as the primary site of inflammation. For epidemiology, I gave you certain percentages. Remember them and mention. And important to mention about bimodal distribution. So whatever I told you from Janos or recent articles can mention. Etiology, do you remember? Hi, idiopathic, infectious, inflammatory, autoimmune, TINU, and malignancy. Just remember this and you can mention everything under just these. This is a trick just to remember. Now you write idiopathic, I divided into two, pars planitis और intermediate uveitis, non-pars planitis type. आप इसको समझा दीजिए. For infection, it is important to mention TB, syphilis, and Lyme. Yeah. For inflammatory, sarcoidosis was important. For autoimmune, you mention MS. For TINU, it is important that you mention kidney and eye association, and malignancy में PVRL, primary vitreoretinal lymphoma. See, the etiology is completed. Regarding symptoms, it is important that you mention floaters and diminution of vision. Signs, I explained. So for signs, you will first mention about the grading of vitritis, then mention about snowball, snowbanking, and then peripheral periphlebitis, peripheral neovascularization, and then all the complications. like VH, TRD, cyclitic membrane, ERM, cataract, glaucoma, and the most important जो सबसे पहले लिखना चाहिए था cystoid macular edema. बच्चों में BSK, band shaped keratopathy. You remember this and just mention accordingly. For investigation, divided into this part, and if you know the etiology, you can just write the investigations. For uveitis, go for CBC, ESR, CRP. For uh, disease specific, तो TB का बता दीजिए, मोंटू chest x-ray, QTB, syphilis के लिए antibody serology, Lyme serology, sarcoidosis test, MS के लिए MRI, TB के लिए beta 2 microglobulin, and for malignancy, you go for diagnostic vitrectomy. And do not forget to mention about multimodal imaging, in which OCT and FFA is important. Otherwise, you can go for wide field imaging, B scan, UBM, and just mention it again. Then the most important part, which is treatment, you can divide into medical, laser, and surgical part. In steroids, you mention about periocular PST. Intravitreal, you mention about IVTA. Slow release implant Oludex, and sustained release implant like Leuven. Then systemic oral steroid. Then mention about immunomodulators like methotrexate, cyclosporine. Biologics may you have to remember adalimumab and infliximab, especially for non-infectious uveitis. And you keep the underlying cause. Jisme TB is very important that you give steroids only and only under the cover of ATT. Remember. Then laser, cryotherapy and laser photocoagulation. So you remember that if you want to more of the inflammation and neovascularization, you go for cryotherapy or laser photocoagulation. And if all this fails, you go for surgery like pars plana vitrectomy and surgery for complications. And wow, beautifully we have completed intermediate uveitis starting from definition to treatment. And if you are interested to know about the recent trials, you can mention in your exams also, and I will be covering this small part in my next video. So this is how we have finished our very important topic, intermediate uveitis. Beyond this, believe me, you don't have to open any book. Just revise this before your exams, one time or two times, and you are done, be it written exam or Viva. All the best. तब तक के लिए, Ophthalmology.